Welcome and thank you for joining us today. I'm Rebecca Munnerlin with the Prisma Health Media Relations team. We are here to bring you facts and news on a health topic that affects many families in South Carolina. According to the Alzheimer's Association, more than 6 million Americans are living with Alzheimer's. By 2050, this number is projected to rise to nearly 13 million, which brings urgency to research and the development of medical breakthroughs to prevent, slow, or cure Alzheimer's disease. Currently, about 1 in 9 people aged 65 and older has Alzheimer's, and almost 2/3 of Americans with Alzheimer's are women. Today, 2 Prisma Health experts will provide information and answer questions about current treatments, as well as the news of promising research and drugs they are following. I'd like to introduce first Dr. Shilpa Srinivasan, board-certified specialist in geriatric psychiatry and in clinical practice at Prisma Health in the Midlands, and Dr. John Absher, board-certified specialist in neurology and in practice at Prisma Health in the Upstate. We're going to go straight to some prepared questions. What is mild cognitive impairment, also called MCI, and how is it linked to Alzheimer's?
Certainly. So good afternoon, everyone. So MCI, or mild cognitive impairment, is really an early stage of memory impairment or change in cognitive abilities like language, visuospatial skills in persons who still maintain their functional abilities for independent living. This is different than age-associated memory change. With MCI, despite these early memory changes, persons with MCI are still able to carry out their day-to-day activities by themselves. However, these cognitive changes are noticeable by the persons themselves, their family members, friends, or loved ones. MCI can be seen in about 12 to 18% of individuals above the age of 60. There are a couple of different types of MCI. One of them is called the amnestic type, where primarily it's a problem with memory, forgetting details, usually learned information, newly learned information. In contrast, there's also something called non-amnestic MCI, and this form usually affects higher order thought processes, what we call executive function, that usually plays a role in planning, sequencing, organizing. Now, individuals who have MCI could remain stable, doesn't progress over time. However, in a subset of individuals, MCI may be an early, or what we call a prodromal stage of Alzheimer's disease, a progressive condition. And usually this occurs in individuals who have MCI and have other biomarkers of Alzheimer's disease that can be picked up on PET scans. But again, they don't have the degree of memory impairment that interferes with functioning. Approximately 10 to 15% of individuals with MCI will go on to develop dementia annually, and about 30% of people with MCI due to Alzheimer's disease will develop dementia within about 5 years.
Thank you, Dr. Srinivasan. Dr. Absher, who is at risk for Alzheimer's?
Well, first I want to say it's a pleasure to be here, and thanks for having me. It's also nice to follow the previous comments, because the first group of people that are at risk for Alzheimer's disease are the individuals who have MCI, or mild cognitive impairment, since it is oftentimes a sort of a prodromal or early stage of an underlying disease process. And as individuals lose their functional status, they progress from MCI into a dementia diagnosis, and many times the diagnosis in question is Alzheimer's disease. Now, having said that, there's also a number of factors that have been linked to the risk for Alzheimer's disease. There are genetic factors. The 3 most common dominantly inherited types, you're probably familiar with presenilin 1, presenilin 2, and amyloid precursor protein gene carriers. And then also you have ApoE4 gene, which is a risk factor gene. It doesn't mean you're going to have Alzheimer's disease if you have ApoE4, but it does put you at higher risk. And once you have a cognitive disorder, there's a risk of accelerated decline. Individuals who have vascular risk factors are at higher risk for developing Alzheimer's disease, and We think that there's a large number of patients who have overlap syndromes where they will have Alzheimer's disease plus some other underlying disease process like stroke-related cognitive impairment or other neurodegenerative diseases or hydrocephalic dementia, et cetera. So a combination of different factors tend to increase your risk for developing a dementia. And specifically, when you're looking at risk for Alzheimer's disease, glucose seems to be a risk, and so individuals with diabetes seem to be at higher risk. Individuals who've had previous head trauma, it seems, are also at higher risk. Individuals who have prolonged difficulties with sleep disorders, untreated sleep disorders, seem to also be at higher risk, and as well as those individuals who have toxic exposures over long periods of time, like alcohol, for example. Drug use is an emerging and increasingly recognized risk factor as well. Individuals who've had COVID-19 infection are at heightened risk. Markers for individuals to develop a dementia syndrome in general. The list is long of risk factors and susceptibility markers for individuals to develop a dementia syndrome in general, and many of those that I mentioned are specific or also affect people who have Alzheimer's disease risk.
Got it. Dr. Srinivasan, who is at risk? I'm sorry. How does the typical progression of Alzheimer's affect patients over time?
Yeah, so Alzheimer's disease, from a clinical trajectory standpoint, is what we would call not only a progressive dementia, but one that is insidiously progressive. And what I mean by that is it's not a condition where someone has overnight changes or day-to-day changes that are drastic or dramatic. Rather, the cognitive disturbances occur and progress slowly over time. In some settings, that can be tracked via screening tools that actually are qualitative, meaning there's a numeric score based on office-based validated tests of memory and cognition that are administered to patients during medical visits to establish a baseline in their cognition, perhaps at the time of diagnosis, and subsequently over time. And on these tools, the numeric score can change or drop by 2 to 4 points per year over the course of a person's illness. It's also important to keep in mind that when it comes to the trajectory or the progression of a condition like Alzheimer's disease, memory is one component of cognition, but it is not the only component of cognition. Rather, we also look at a patient's function and behavior over time, both of which can also be affected by the disease. By that, I mean that the things a person can do for and by themselves today may not necessarily be patent a few years from now. Those functional abilities, what we call activities of daily living and instrumental activities of daily living, can be progressively impacted over time as well. And lastly, when it comes to behavioral changes because of dementia, we know that anywhere from 60 to 90% of people with Alzheimer's disease over the course of their disease progression can develop behavioral changes. These can include things like changes in sleep patterns, anxiety, mood changes, personality changes, or even more severe behavioral changes, including things like restlessness, agitation, verbal or physical, or even psychosis, such as hallucinations. And these symptoms can occur at different time points depending on the progression of the disease. We think about this condition as going from mild, moderate to severe, and that's primarily based on an individual's function and the progressive changes or loss of functions over time. And some of these behaviors that can be seen early in the course of the disease may attenuate as or lessen as Alzheimer's disease progresses, and new behaviors may emerge later on in later stages of the disease as well.
Dr. Absher, we've spoken, Dr. Srinivasan has spoken to some of the behavioral indications that would lead to an Alzheimer's diagnosis. Can you tell us a little bit about other ways that patients are diagnosed with Alzheimer's to confirm that diagnosis?
So there's an increasing interest in biomarkers to confirm a diagnosis of Alzheimer's disease. The characteristic pathology in the brain includes amyloid deposits in the brain, which are extracellular clumps of material. Amyloid is a protein that gets deposited in the brain. And then there's also intracellular deposits in nerve cells in the brain of tau protein. And so flaxen tangles, they're called, and those are the two pathologic hallmarks. And so biomarkers that can detect the presence of amyloid or tau protein are of great interest. And so now we have spinal fluid testing that can measure these substances and appraise the risk of having Alzheimer's disease in individuals who already have a dementia diagnosis or who may have mild cognitive impairment. There's also been a recent development of a blood test that is recommended only for individuals who have a diagnosis of a dementia syndrome, and you're trying to determine whether or not they're likely to have the presence of amyloid in their brain. And so if in individuals who have positive blood tests, the likelihood of them having amyloid in their brain is higher. You can also look at the brain directly with functional neuroimaging studies. For example, positron emission tomography can be done in individuals who've been injected with a radio tracer, a radioactive substance that binds to the amyloid or that binds to the tau protein. And this not only tells you how much of those proteins they have in their brain, but also where they're located. And so functional imaging is another thing that can be done. So there's other testing that can be helpful, such as neuropsychological testing. It's sort of the next level of cognitive testing that above and beyond what we do in the office normally to follow patients or to screen them. And neuropsychological testing can be very helpful because it can reveal characteristic patterns of cognitive deficit that we tend to see in most patients, or that can be a reliable indicator of Alzheimer's disease. So none of the tests are perfect. We do not have a perfect test, and part of the rationale for that is because Alzheimer's disease includes many subtypes and varieties, and some people may not have the same. Well, most people have a slight variation on a common theme.
Dr. Srinivasan, is early diagnosis important, and what are the current treatment options?
Sure. Early diagnosis is indeed very important. This is a progressive neurodegenerative condition. So the sooner it can be diagnosed, the earlier it can be diagnosed, the earlier treatment interventions can be implemented. And those treatment interventions have an impact not just on the patient, but also family members and caregivers who are involved in the overall aspects of care. We know that just in South Carolina, according to data from the Alzheimer's Association, we are projected to see a 26% increase in Alzheimer's dementia cases between 2020 to 2025, so just over a 5-year period. What we also know is that nationwide mortality rates due to Alzheimer's have increased over the last 2 decades by 146%. So this is really staggering. So intervening early and instituting treatments and resources early is really optimal and at times even critical. So early diagnosis can mean patients and their families are afforded the opportunity to benefit from treatment options and perhaps even to participate in clinical trials research, which in the current state is really geared towards individuals with early stages of the disease. Currently, the state of available treatments is that these are geared towards slowing down the rate of progression of the illness, meaning slowing down how quickly memory, function, and behavior changes occur over time relative to not being treated at all. But our current treatments are not disease modifying, meaning they don't change the course of the disease. What we have available as far as the current FDA-approved treatments are primarily in the form of oral medications that are taken every day. There is one version that comes in a skin patch, which is again administered every day, and combination treatments. One class of medications that we commonly prescribe is called acetylcholinesterase inhibitors that works on the neurotransmitter acetylcholine in the brain that is involved in memory function. And another category of medications is called the NMDA receptor antagonist, which works on another neurotransmitter called glutamate, which is thought to be in pathologic states excitotoxic to the brain and therefore harmful. So this combination of medications is what is commonly prescribed. However, we do have the emerging field of novel therapeutic agents, one of which has received FDA approval recently, and this includes the category of immunotherapeutics in the form of monoclonal antibodies, which again is an emerging and growing aspect of Alzheimer's treatment research. In addition, as far as treatments go, depending on some of the behavioral symptoms that I talked about earlier, other symptomatic treatments may be also added. This may be medications to help with sleep cycles, if sleep cycles are disrupted, medications for mood or anxiety or those psychotic symptoms. So really, the constellation of treatment, while medications are a part of it, early treatment also includes incorporating caregivers and their families to the patient's care, because recognizing that this is a condition, Alzheimer's disease is a condition that not only affects our patients, but it affects their families, their loved ones, their caregivers, their communities. And so this is really having a very cohesive approach to engage patients, their families, their caregivers, so that they're not going it alone. And ultimately for us in the healthcare team to walk alongside them in that journey.
Great, thank you. Dr. Absher, on this question, I'd like to hear from both of you, but I'll start with Dr. Absher. What is your sense of the progress in current research for better treatment? Is the focus on finding a cure or slowing the disease down?
I think the answer is both. I mean, I think there's interest, of course, in finding a cure. And one way to do that would be to identify patients in what's called the pre-symptomatic stage, and then to fix the underlying problem that causes them to progress. So naturally, it makes sense that a disease-modifying therapy that slows down the actual progression of the nerve damage in the brain, that would be a step in the right direction. So I think we're making some progress in this regard. It's been a very difficult area to fix or to address pharmacologically for a number of reasons. The diversity of the clinical subtypes of Alzheimer's disease is one issue. The target to direct our immunotherapies toward is another. So for many reasons, it's been difficult. But I have a lot of hope that we're starting to find treatments that may move the needle a little bit. And then hopefully this will lead to other discoveries that will help us to move the needle quite a bit to catch the disease when it's very early in its manifestations, perhaps even in the preclinical stage.
Dr. Srinivasan, do you have some thoughts on that?
Yeah, I would echo the sentiments. I too am very hopeful, and I think this is a really exciting time to see the enthusiasm and the interest, as well as the advocacy for Alzheimer's research, which has really stagnated for a while. When you think of the last FDA-approved medication for Alzheimer's disease came out over a decade and a half ago. And it wasn't until last July when we had the first novel therapeutic FDA approved. So there is a lot of enthusiasm. And I think our patients and families are very deserving of this momentum. And there definitely is and needs to be a lot more in funding. And we're finally at the point where this is being recognized as a critical need.
Dr. Absher, you've talked a little bit about this, but I was wondering if you could explain to us exactly what amyloid plaques in the brain are.
Well, sure, I'll give that a try. The amyloid is a protein that's developed by the body, and all of us have amyloid in our system, and we normally can process that amyloid and remove it from our body and our brain before it tends to cause any trouble. So the realization that we have clumps of this protein in the brain led to the theory that if we get rid of those clumps, or if we can prevent them from forming in the first place, then we may be able to shut down the disease process and fix the problem of Alzheimer's disease. So that's the amyloid hypothesis in a nutshell. So amyloid precursor protein is sort of extrudes from the cell, and then there are enzymes that chop it up into pieces, and some of those pieces glump together. And so you have what's called protofibrils, and then they clump together into monomers, and then the monomers clump together into oligomers, and then the oligomers clump together into larger strands, and then eventually the strands will get tied up and folded and fold up into amyloid plaques. And these are the big clumps of extracellular deposits that you see on them under the microscope or when you do imaging. So there's many of the targets that have been developed for therapeutic use aimed at preventing progression of the neurodegeneration have been targeting the amyloid. And so there's been enzyme blockers to prevent the cleavage of the amyloid precursor protein, and there's been other agents to try and prevent the monomers from clumping together into larger pieces and to prevent the misfolding from happening. And then this new round of treatments, the aducanumab and the lecanemab, are directed at the very earlier stages of that amyloid cascade 1. The aducanumab directed at the monomers, I believe, and prevents them from clumping together, and it actually can remove amyloid deposits from the brain fairly well. The lecanemab can also remove the deposits that have already occurred to some extent, and also targets those early stages. In this case, it's the protofibrils that are affected by the lecanemab. And so in that way, we're trying to stop those deposits from building up. And we know that amyloid itself is toxic to nerve cells. If you take an experimental model and you inject amyloid, then the cells nearby will start to wither and eventually die from the toxicity of the amyloid. And so this, even though it may not be the whole picture to prevent progression of disease, there does seem to be value in eliminating the toxic effects of amyloid and preventing the buildup as much as we can.
Many of us first heard of monoclonal antibodies related to treatment for COVID-19. So I think many of us sort of perked up our attention to realize that this research was also being applied to Alzheimer's. And you've covered that to some degree just now. Is there anything else you would say about your thoughts on lecanemab that's right now, I believe it's just finishing up its phase 3 trials?
Well, I guess my bias is that I would like these types of treatments to be more widely available, because even if we are only making a relatively modest impact in the disease progression, my bias as someone who treats these patients and sees the misery it causes for the patients and their families, I believe that it's important to take advantage of even those small steps that we make in the right direction. And then we can continue to work on additional steps that may help to shift the curve in a more favorable direction going forward. The biggest argument against that has been the cost and the scans, the PET scanning, and the monitoring for adverse side effects that needs to be done. Those sorts of costs are high. But I would argue that the costs of the disease are tremendous, and we know that from the Alzheimer's Association and other work that's been done worldwide showing us the financial costs and the cost of society are absolutely huge.
Dr. Srinivasan, you had some thoughts to add on that point?
Yeah, I think what's also really interesting about lecanemab, in addition to the points that Dr. Absher has raised, is that with this particular agent, the study that have been conducted, the first 18-month trial, the phase 3 trial that was just published last week, has shown that not only was there a reduction in amyloid burden demonstrated by this medication in individuals in the research trials who were in the lecanemab arm versus placebo, but there was also a drop in the decline on cognitive screening scores that were administered to participants in the study. So there was both biomarker change as well as change numerically in the rate of decline on these validated instruments that were used in the research study. Where for us, I think we need to see where the rubber meets the road, so to speak, is what this means in terms of clinical benefit in the real world for patients, recognizing that this study was over 18 months. The disease, of course, does not stop at 18 months. It continues. So I think there's a lot more data that we can hopefully look forward to seeing, but it's certainly a step in the right direction. And as Dr. Absher mentioned, and as I see with my patients as well, this is a devastating condition. And, having more of these therapies emerge, having data from these rigorous clinical trials emerge is really where we need to be headed.
Thank you for that. I'll just continue with you, Dr. Srinivasan. Are there other areas of mild cognitive impairment, dementia, and Alzheimer's research that you are closely watching?
Yeah, I think this is really a really evolving area, and recognizing that this is an evolving field, a lot of the clinical trials that are going on right now have open label extension studies that are doing exactly what we were talking about, which is we need to look at that longer term data. So some of these clinical trials of monoclonal antibodies are looking at extensions, longer treatment arms, to look at data over a period of several years, some up to 5 years, to see if the clinical benefit that is being that is manifesting in the current clinical trials, if that will continue to hold over a period of time. This is particularly relevant not only for efficacy, meaning how well does the medication work in terms of showing clinical benefit, but it also has critical implications for safety, because we've seen from these studies that there are safety concerns that have shown up in the form of amyloid-related imaging artifacts, or ARIAs, specifically in the form of effusions or swelling and bleeds in the brain. So we need that longer-term safety data to see if they are ways to identify who's at risk for developing those and how do we mitigate that. Recognizing that these medications are being used to treat individuals early in the stage of the disease, we want to make sure that these treatments are geared towards improving quality of life in the long run, and some of these side effects may have an adverse impact on that quality of life. So some of the things that I'm also really interested in looking at the findings from is a clinical trial that's actually comparing two different monoclonal antibodies, one called donanemab and the other one is aducanumab. So this is an active comparator study. So they're looking at how these two perform in clinical trials when they're actively compared to each other. There's also a study called Trailblazer 3, which is a clinical trial testing donanemab in cognitively intact individuals, so people without dementia who are at risk for Alzheimer's based on their biomarker profiles. So this is really intended to test medications in a population that is at risk for dementia, but does not currently have cognitive symptoms. So this is really interesting because it's really looking at this from a preventative standpoint rather from a treatment standpoint. So these are just some of the very many clinical trials that are ongoing, and certainly bears watching.
Dr. Absher, sort of tailing right onto that point, do you think preventive treatments will be the key to reducing or eliminating Alzheimer's?
I do. I think, we've all seen, those of us who see these dementia patients in our practice, we've seen people that exercise, they have great diets, they get plenty of sleep, they don't drink alcohol, they don't abuse themselves in any way, and yet they still come down with Alzheimer's disease. They're sort of models of health. And so, there must be some other approach that targets the underlying neurobiology of the disease. And I like very much the studies that were mentioned and the need to attain long-term data that prove that we can bend the curve. A couple other areas that come up, there's the dominantly inherited Alzheimer's disease network, and they're looking at some of these molecules, these monoclonal antibodies in individuals who carry a gene. If you have the gene, you can be identified many years before developing the disease. And therefore, there's an opportunity to really stop it before it starts in that population. So I'm very curious to see what happens in that type of research. Yes, I think that preventative therapies are going to be critical, because once you have the disease process, the destruction has happened, you will likely have great difficulties restoring much of cognitive function at that point. And so we'd like to stop it before the nerve damage is done.
Dr. Srinivasan, bringing us back to where we are today, do you mind recapping the signs of dementia or MCI, and then following on that with what a parent, what we can do for a parent, or if a loved one begins to show those signs?
Sure. So in terms of the signs of MCI, as I mentioned earlier, MCI is characterized by memory changes that don't necessarily interfere with day-to-day functioning. So in individuals with MCI, they may have difficulty with memory, with cognitive abilities. It may be apparent to them and to family members, but they're still able to go about their day-to-day tasks and activities. It may perhaps take them a little bit longer to balance their checkbook, whereas ordinarily they may have done it at a brisker pace, or they may require other compensatory maneuvers, but are still able to function and manage and orchestrate their day-to-day activities independently. In contrast, when cognitive functions progress, or cognitive dysfunction progresses further to where it starts interfering with independence in activities of daily living, that's when we really start to look at other components. For example, memory changes that disrupt the ability to live independently, whether it's with what we call instrumental activities of daily living or basic activities of daily living. Instrumental activities are those higher order thought processes, or require higher order thought processes like planning, sequencing, organizing. So someone who has difficulty manipulating finances, balancing their checkbook, paying their day-to-day bills, maybe problems with visuospatial skills like depth perception, problems with driving, problems with shifting attention, having difficulties with those day-to-day tasks, and progressively having issues with maintaining independence that way can be significant warning signs. The other thing would be poor judgment or difficulty with making complex decisions, withdrawing from activities, whether it be with friends, family, work, or memory changes along with changes in personality, mood, or behavior can all be signs to watch out for and would then be reasons to consider evaluation. In terms of what to do if one's parent or loved one shows signs of dementia, I think this is really, again, a situation where it's very important, first and foremost, to understand that while not all memory changes may mean that the person has dementia, it's still best not to take those memory changes lightly. One step would be to have discussion with your parent or loved one about your concern, but anticipate that that discussion may sometimes be met with relief or acceptance, but may at other times be met with perhaps some resistance or denial. But at least starting that broaching that topic. The first step, I think, in terms of looking at where to go and what to do from an evaluation standpoint would be to engage in discussion with your loved one's healthcare provider or the healthcare team, because they can really serve as that hub in the wheel to start linking in specialists or other specialty evaluation components. There may be medical workup that needs to ensue, and usually the start is with the primary team. Lastly, for family members, it's really important to recognize that you're not alone in this process, and getting connected with caregiver resources, educational resources, and community resources can be very helpful, so that, again, this is very much a team approach in embarking on that journey of managing and treating dementia.
Dr. Absher, if you have a family history of Alzheimer's, when should you think about being assessed? And is cognition testing now a part of routine health care for older adults?
So those are great questions. Short answer is we don't really know the best answer to that, the first question. And the second question, I think, is ideally yes. So to expand on that, I think that if you're concerned about any cognitive change, then you should be assessed. We now know that there's this phenomenon called subjective cognitive impairment, which is even an earlier stage when you notice that there's something that's not quite right, but no one else seems to be able to tell, even when they do the cognitive testing. And yet, those individuals still are shown to have a higher incidence or rate of going on and developing a dementia syndrome, and in many cases, Alzheimer's disease. So if you have a concern yourself, then you should be assessed. If you have family members that are affected, that doesn't usually portend, that bad things are going to happen to you. The reason for that is because it's such a common illness that many times there's someone in the family who has been affected, and that may have nothing to do with genetics or your particular risks. On the other hand, if you do have what are called first-degree relatives, like siblings, parents, children, if those types of relatives are affected, or if you have several generations, like mother, maternal grandmother, maternal grandfather, all affected in sort of a dominantly inherited type pattern, passing from one generation to the next, then certainly you should be assessed, because it's possible you may have one of those dominantly inherited Alzheimer's type genes. So the other thing that many physicians are doing is screening for the ApoE4 gene. And this can be a little confusing because many individuals in the population with the ApoE4 gene will never go on to develop Alzheimer's disease. If you do happen to be unlucky and develop Alzheimer's disease, your disease will progress more rapidly if you have the ApoE4 gene. And so it's usually better done after a diagnosis has been established, in my view. But it's a difficult question to know exactly how family history plays into this. We also know that it's important to have greater access than we have right now to genetic counseling in those individuals who are found to have the genetic risks that I've discussed, because there's a lot of confusion about this, and people need to have professionals who understand the genetics to be able to explain things to them in a very straightforward way.
Dr. Srinivasan, this is our last question. What are some resources that you recommend for more information about dementia and Alzheimer's? And then I'd ask you if you'd like to just give us some final thoughts on the topic.
Sure. So from the standpoint of resources, really, if we're looking at it from a national level and then, of course, from a local level. So I think on a national level, I certainly recommend established entities like the National Institutes on Aging, the Alzheimer's Association. And on a more of our state level or local level, the Alzheimer's Association has chapters across the Midlands, Upstate, and the Low Country. So I certainly think this is a valuable resource for patients, family members, caregivers, and as well as for us in the healthcare team to recognize and see what's available in our communities. The Department on Aging's Alzheimer's Resource Coordination Center here in South Carolina, as well as the Aging and Disability Resource Center, is very helpful. I also want to put a plug in because I think this is a tremendous program that we offer at Prisma, as well as something called Dementia Dialogues, which is really geared towards family members and caregivers to really provide education about dementia, and on a very personal and informal level, have the ability for family members and caregivers to engage with one another in a system of support. So these are just some of the resources that I use, and I also recommend to patients and family members. In terms of wrapping up, first of all, I want to say thank you for this opportunity and this invitation to be with you all this afternoon, and for such thought-provoking questions, and also to hear Dr. Absher's responses to a lot of these questions as well. I think we all recognize that Alzheimer's disease is a condition that takes a significant toll on individuals, on their families, on their loved ones, and as I said earlier, on our community and our society as a whole. I think we're on the cusp of a really exciting time. We've started seeing momentum and movement. We've started seeing emerging novel therapeutic agents. So this really heralds the onset of a time when this condition is coming into the light in a way that it needs to come into from the standpoint of research, clinical trials, and treatment options for an incredibly deserving population that we need to continue to strive ahead with our current goals certainly being management, but hopefully ultimately the goal being prevention and or cure.
Thank you so much. Dr. Absher, do you have any final thoughts you'd like to share?
Well, I want to just echo all of those sentiments, and it's been nice to see the progress that's starting to occur in this field, and to feel as if we can share that ray of hope with our patients, and because they certainly are looking for any ray of hope that they can get. And so I certainly have been happy to see the movement towards approved drugs and ongoing research aimed at slowing down the progression of the disease. And I think we're also getting better at our systems of care to help coordinate both the assessment of individuals who are at having symptoms, and to walk them through the process of their disease course, and to get them into the capable hands of the help and services that they need. And so I'm very pleased to be involved in this particular area of healthcare at this time, and appreciate everyone's interest.
Thank you so much. I think we have covered the questions that were posted along the way in the course of y'all's answers. So I do appreciate everyone's participation. Dr. Absher, Dr. Srinivasan, I think you all shed a lot of light on this topic for us. So again, I appreciate you participating with us. We'll be able to share this recording later with our participants, and we will also make it available on our social media channels later on. So that's all for now, unless anyone has anything they'd like to add.
Thank you very much.
Yes, thank you.
Appreciate it. Thank you all. Have a great day.